Thank you, Sarah, for that kind introduction. I think it's so amazing to see meetings like this where we are not just reviewing, but we're also renewing. Hopefully it starts a new type of meeting and we incorporate these types of things into all of our meetings going forward. So let's switch gears a little bit and talk about breast cancer, specifically genomics for treatment planning. And on a broad level, I just want to start by highlighting the decision time periods that or decision points that we have to make for patients with early stage hormone receptor positive breast cancer. So first is that initial diagnosis where we have a woman who has an endocrine sensitive tumor and we know that she's going to receive endocrine therapy, but does chemotherapy additionally benefit this patient? And this decision impacts a large percentage of patients with breast cancer as shown on this pie chart. 70% of tumors are hormone receptor positive, and in terms of absolute numbers, 1.25 million cases of hormone receptor positive invasive ductal carcinoma yearly worldwide. So certainly a huge impact for a great majority of these women. This slide used to say 2 therapeutic decision points, and I had to addend it to make it 3 because excitingly, we now for the first time have an adjuvant CDK inhibitor as an option for women with high risk early stage hormone receptor positive breast cancer. So we'll go through the data that led to the approval of abemaciclib in that setting. And then at the time point of 5 years post-diagnosis, fortunately, we've done a good job. A lot of our patients remain disease-free, 75%, but unfortunately, we're still having about 25% of patients recurring. 40,000 women and men are dying of breast cancer per year. And for these women, do we need to extend hormonal therapy, and how do we make that decision? We know that this type of breast cancer is a disease of late recurrence with over 50% of recurrences and 66% of deaths occurring after 5 years after initial diagnosis. So first, let's go through that first decision point of chemotherapy and how did we used to make that decision? Well, historically, we've relied on clinical and pathologic factors as shown here, including tumor grade, size, ER status, HER2 status, lymph node status, and menopausal status. And then we had adjuvant online, and I don't know how many of you remember this. I remember having conversations with patients when I was a fellow, and I'd pull this up and talk about how age and ER status and tumor grade factor in. But we now, fortunately, have moved into the era of genomics and understanding that we have the ability to provide more individualized risk of recurrence or the presence of a prognostic biomarker. And then there are also biomarkers or genomic assays that are also considered predictive. So with that in mind, I'll just call to your attention the recent ASCO guideline update with regards to the use of these biomarkers for adjuvant endocrine and chemotherapy in early stage breast cancer. And let's start in the middle as we're discussing ER positive disease. And let's talk about the decisions that are somewhat easier for the postmenopausal women over 50 who are node negative. You notice that there are a variety of assays that the ASCO guideline update recommended consideration to use, including Oncotype, MammaPrint, EndoPredict, and Prosigna. And then shifting to the postmenopausal node positive patients, 1 to 3 positive nodes, we also have a variety of assays that we could consider using. And if you think about it, this is really such dramatic progress, right? Because there was a time that over a centimeter tumor size would mean that a woman would take chemo or would be recommended to receive chemotherapy. And now we have postmenopausal women with node positive disease where we can safely forego chemotherapy based on a genomic assay. So that's remarkable progress. Unfortunately, for patients with 4 or more positive nodes, there's insufficient evidence to recommend a biomarker for use. And then shifting To the other side of this algorithm, the premenopausal women that are defined as age less than 50, node-negative oncotype is the only assay that's recommended, although I would argue that I don't think there's any assay that's been able to show a benefit to chemotherapy in an exclusively clinically low-risk population. And then in the node-positive situation, they recommended that there was insufficient evidence to recommend a biomarker for use. So why is that when we have studies like MIND-ACT and Rxponder that included premenopausal women with node-positive disease, why did the guideline committee say that there was insufficient evidence? Well, let's start by reviewing the Rxponder trial. This was a very important study. It enrolled women that were with hormone receptor positive breast cancer, up to 3 positive nodes, were suitable to receive chemotherapy. And if they had a recurrence score of over 25, they were off study, because there you have clinical high risk based on node positivity and a genomic assay that clearly shows this woman needs chemotherapy, so it wouldn't have been appropriate to randomize that patient. If the recurrence score was between 0 and 25, those patients, of which there were 5,000, so this was a huge trial, were randomized to either chemotherapy followed by endocrine therapy or endocrine therapy alone. You see the stratification factors: recurrence score 0 to 13, 14 to 25, menopausal status, and axillary surgery. So as we look at invasive disease-free survival stratified by recurrence score and postmenopausal status, we saw in the postmenopausal women, even if you had a higher recurrence score, 14 to 25, there was no statistically significant IDFS difference. And that was the same with the lower recurrence score. So remember, as we looked at that algorithm and we saw on the right-hand side node positive patients that are postmenopausal, we could consider using an assay, because we did see that the assay was helpful in this regard. Now, in the premenopausal patients, even if you had a higher recurrence score of 0 to 13, there was a 5-year IDFS absolute difference of 3.9%, and with a recurrence score of 14 to 25, there was an absolute difference of 6.2%. But what was interesting about this is, in these women that were premenopausal with node-positive disease, there was a lack of ovarian suppression use. 84% in the endocrine chemo arm got tamoxifen as monotherapy, and 75% in the endocrine therapy alone arm, which is kind of surprising if you think about it, because these are node-positive premenopausal women, and we know the benefit of ovarian suppression, as I'll show you in the next slide, based on the soft and text data. So this finding of a chemotherapy benefit in premenopausal women is not something that was unique to the Rxponder trial. The MIND-ACT study, which also included these patients, they were clinically high risk, genomically low risk, and the panel up on the top of this were the premenopausal patients. You see again that separation, the benefit again of chemotherapy, which was very similar to what was seen in Rxponder, but the graph on the bottom showing the postmenopausal women with no benefit. So the thinking here is it really the chemotherapy that is causing a cytotoxic effect in eradicating micrometastatic disease in these women? Or is it the induction of menopause? Because the majority of these women did not get ovarian suppression, and perhaps it is the fact that the chemotherapy induced menopause in these women, and that's what they're really benefiting from. So as I mentioned, in the soft overall population, which was a study looking at the use of ovarian suppression, you see summarized on the bottom tamoxifen plus ovarian suppression versus tamoxifen alone. There was an absolute reduction in distant recurrence and death, and the same with exemestane and ovarian suppression. And then looking again at the 12-year update of soft and text, you see the additional benefit of aromatase inhibitors over tamoxifen, as summarized on the bottom. So how are we going to answer this question, right? Whether it is the chemotherapy or ovarian suppression induction with the chemo? Well, this is a study that the NRG is about to launch, the BR009 trial, and here you see a direct comparison of chemo plus ovarian function suppression and hormonal therapy versus ovarian function suppression and an aromatase inhibitor. So this is a randomized trial, and this will hopefully give us the answer, but I would say that this is going to be a question that is going to be around for a long time, because this trial is going to take a long time for us to get the answer to this very important question for our premenopausal women. So now let's move to that second decision point. I mentioned the availability of adjuvant abemaciclib for patients at high risk, early stage HR positive, HER2 negative breast cancer. That therapy was approved on the basis of the monarchE trial, which is shown here. You saw these women who had high risk disease. So cohort 1 was based on clinical pathologic factors. They had 4 or more positive nodes, or if they had 1 to 3 positive nodes and another high risk feature, including a larger tumor size or a grade 3 tumor. And then cohort 2 was high risk based on Ki-67 with the additional requirements shown. These patients were randomized 1-to-1 to abemaciclib plus endocrine therapy versus endocrine therapy alone, and the primary endpoint was invasive disease-free survival. How was high Ki-67 defined? Well, first of all, it was centrally assessed, and we all know that there are issues with Ki-67 testing and concordance of testing among local pathologists, so this is something that has become a very practical point. Less than 20% was defined as low, greater than or equal to 20% was high. And what we saw was an IDFS benefit that was maintained in the intent to treat population with longer follow-up of 27 months. There was an absolute improvement of 2.7% and 5.4% for the 2- and 3-year IDFS rates, respectively. And here you see the IDFS in the intent to treat population over 20% high Ki-67, as well as in cohort 1. And what really drove, I think, the FDA in approving this based on the high Ki-67 requirement was you see the magnitude of benefit in these patients was much higher, approaching over 7%. So Ki-67 is prognostic, but it was not predictive of response. Yet we do see the approval based on that high Ki-67 group. In terms of safety, we are familiar with this drug because we have given it now for a while in the metastatic setting. We know that neutropenia is an issue, not as much as some of the other CDK inhibitors, but still you see here the AE summary, and you see 46% neutropenia, which is not unexpected, and some diarrhea as well. And then you see among the over 2,000 patients who experienced diarrhea, which is the other major side effect, you see the median time to onset of any grade was 8 days. About 20% had 1 or more dose reductions. About 23% had dose holds. And then the other thing to keep in mind with this drug is that there is an AE of special interest, venous thromboembolism, which we have to be mindful of. So as I mentioned, the FDA has approved abemaciclib and endocrine therapy for patients with high-risk hormone receptor positive, HER2 negative, node positive early breast cancer with a Ki-67 score of over 20%. And what you see on this slide is summarized the FDA-approved indication and the ASCO guidelines, which have actually recommended consideration of abemaciclib in a broader population, meaning any patient that would have met criteria for the trial in the intent to treat population. So there is a little bit of a difference there in terms of the FDA-approved indication and the ASCO guidelines. So now let's shift to the third time point in the decision-making process for these patients, the issue of extension of endocrine therapy. And so why are we thinking about extending endocrine therapy in certain patients? Well, it has to do with the problem of late recurrence. And I think as many of us have treated women with HR-positive disease, we know that recurrences can happen late, and if you look on the graph to the left, you see an analysis which was a meta-analysis of 88 trials, over 62,000 women, and they were disease-free at 5 years, and then they were followed between years 5 and 20. And they did regression analyses looking to see what the impact of tumor size, nodal status was. And what you see here are some pretty worrisome risks of late recurrence, even for smaller node-negative tumors. But I will say that I think this analysis likely overstates the problem in the modern era because our treatments have gotten better. And this analysis also included HER2-positive patients, and we know those patients have a higher risk. In fact, these data were updated at San Antonio in 2019 and looked specifically at those diagnosed after the year 2000. There was a 30% lower risk of distant recurrence compared with women diagnosed before 2000. And you see the recurrence rates summarized here, which were a little bit less than what was previously reported. This being said, I would say that even though these numbers are small, I always tell patients, you know, if something happens in 2% of patients, if it happens to you, it's 100% to you, right? So we definitely still have to be able to identify who these patients are. Well, we know that extending endocrine therapy benefits up to about 5% of women if you look at the absolute benefits. And in this slide, you see summarized several of the trials that have looked at extending endocrine therapy beyond 5 years with either tamoxifen or tamoxifen initially followed by an aromatase inhibitor. There's a pretty consistent number. It's around 3 to 5% absolute benefit from an additional 5 years. But that comes with toxicity costs. So we know that adjuvant endocrine therapy has significant side effects. There are life-changing quality of life side effects with both tamoxifen and aromatase inhibitors, hot flashes, sexual dysfunction, myalgias, arthralgias, cognitive dysfunction. We're even seeing some cardiac issues with longer follow-up. Life-threatening toxicities have also been reported, including thrombosis and endometrial cancer. And again, I mentioned cardiovascular, which is something that we're increasingly identifying, and of course, osteoporosis and fractures. So we know that compliance is a significant challenge. As you look here and you see that poor compliance negatively affects outcomes, not sticking with the treatment plan in the adjuvant setting is associated with worse outcomes. And you see that in this analysis by Dr. Dawn Hirschman, about 30% of patients are discontinuing, and I think some of these women are discontinuing and are not necessarily even being honest and telling their physicians because they feel that you know, maybe they don't have that open patient-physician dialogue, which is something that we have to, as physicians, be better you know, to explain to women that they have to be honest in their side effects and see what we can do to help manage those toxicities. So what we really aim to do is optimize selection of candidates by identifying potential determinants of late risk other than clinical pathologic factors, assess the biology of the primary tumor to more clearly define the risk of late recurrence and the benefit of extended endocrine therapy with multi-gene expression assays. So here you see that there are several gene expression profiles that predict the risk of late recurrence, and I think this is a bit of wordsmithing here because as we say predict the risk of late distant recurrence, that's really prognostic, right? Not predictive, but here you see many of these assays are prognostic. The breast cancer index has been an assay that has in multiple studies also identified the ability to be predictive of benefit to extended endocrine therapy, and you see those multiple studies where BCI has been validated, summarized in this table. The only exception here is this issue of the B42 trial, but as pointed out on this slide, there were a proportion of contribution of contralateral disease to the treatment effect in that trial, and you know, BCI is not intended to look to see what the risk is of contralateral tumors. just pointing out that this assay has been included in the NCCN clinical practice guidelines as the only assay that's predictive of extended endocrine therapy benefit. So here are my conclusions for genomics for treatment planning for breast cancer. The incorporation of genomic assays has allowed us to better tailor our treatment recommendations for hormone receptor positive, HER2 negative early stage breast cancer. For the premenopausal woman, are we dealing with a benefit to chemotherapy, or is it the induction of menopause with ovarian function suppression based on the chemotherapy? Well, we don't have that answer as yet. Stay tuned. There are studies ongoing that will hopefully help us identify the correct approach. Consider adjuvant abemaciclib for high-risk patients. This is our first advancement in the adjuvant setting for early-stage breast cancers in many years, and that's certainly gratifying. And then lastly, careful selection of patients for extended adjuvant endocrine therapy with the breast cancer index endorsed by NCCN as the only predictive assay for this decision. And with that, I'm happy to take any questions.
What assay are you using for Ki-67 for the purpose of abemaciclib?
So I'll repeat the question. So in case someone online didn't hear, the question was, what assay am I using for Ki-67? I think that assay, in our institution, we are now locally doing Ki-67. At my prior institution, we were sending it out. I think there are a variety of laboratories. I believe Quest and others do perform Ki-67, but I think the issue really is in that concordance, which is quite a bit variable, because Ki-67 is somewhat subjective, and I think that's where I've really struggled with using that. I've been considering adjuvant abema in the intent to treat population as per the ASCO guidelines.
Question from the audience. With T-DXd approved in metastatic HER2 low setting, how would HER2 low classification drastically reshape neoadjuvant and adjuvant therapy algorithm?
That's a great question.
What about HR low category?
Yeah, so hot off the presses just yesterday, based on the DESTINY-Breast04 trial in the metastatic setting, T-DXd or trastuzumab deruxtecan was approved for HER2 low disease. This is a huge step forward, which will impact a large percentage of women with HER2 low disease in the metastatic setting. And our general paradigm is whenever we see a drug that's so effective in the metastatic setting, the natural question is to always consider moving it up to the neoadjuvant or adjuvant setting. We are just starting to see trials come out addressing that right now. Those studies are just now starting to enroll and being formulated, so we certainly don't have any data to support using it in the earlier stage setting at this point.
One more question? For early stage breast patients that are node positive, hormone receptor positive, HER2 0, I'm going to say, not low, they're BRCA positive. Are you obviously using olaparib or PARP inhibitors and not considering abema?
Yeah, I think that's a great question. So based on the Olympia trial, we have the approval of adjuvant PARP for patients that harbor a germline BRCA mutation. And recall that approach was associated with the survival benefit, an overall survival benefit. So in my practice, if I have a patient that is high risk and would have met criteria for both interventions, I would use the PARP inhibitor in that situation. I've heard some physicians talk about sequencing, so doing the PARP, and then we don't have data to support that. Certainly, I wouldn't consider combining the two. We don't have safety data for that approach, but I would use PARP.